Okay, so as I was saying, you'll be stuck with these patients and you'll need to evaluate what do we do with them. And I'm going to disappoint you. Why neurologists have the shortest necks in the hospital? We don't know. So we don't know what to say, we don't know what to do, and this is mainly due to the fact that in terms of neurocritical care, because this is what we're talking about here, we're coming out of there, well, maybe Middle Ages, because we weren't able to measure anything in our black box before that. And the first good literature that has come out with, a protocolized algorithm way of deciding things were published by Levy in 1985, now 30 years ago now. And, the outcome is bad, okay? And what we learned from this trial is that if you're still in a coma after 7 days, or if you're in a persistent vegetative state at 30 days, you won't do well, okay? And this has hold over time. But things were refined, and this is because of corticolaminar necrosis, with a small, thin rim of neuron that you lose between a gray and white matter interface, and it's so thin that you cannot even see it on advanced imaging techniques now. So that's why we've been having problems making diagnosis and clarity in this field. So, but what you have a few things that can help you decide once the patient is in your unit and not waking up. So you have to start with the premorbid condition. Obviously, age, neurologic history, potential for rehab. If you start with something so-so, you won't have a good recovery. So this is the first step, and quite obvious. And then this trial tried to look at things that are pertinent to the arrest itself, and it used an algorithm to try to define while you're performing CPR, when can you arrest. So if the arrest was witnessed, or if you had a shockable rhythm and the ROSC occurred in 10 minutes, well then you had a 20% chance of discharge. If you didn't have one of these, well, you had 1% chance of being discharged. So once the patient is in your unit, you have to go back and what happened? How did it went on? Then this meta-analysis looked at clinical factors that can predict outcome, but what's interesting is it summarizes the outcome of roughly 2,000 patients over the year before the era of therapeutic hypothermia, and 70% patient had bad outcome. So we're moving away from the 90% bad outcome, but still a lot of way to go. And then you have the TTM trial that has been published, and now we're down to 50% bad outcome or 50% good outcome, depending on which way you want to see it. And what's important to the take-home message also from this trial is that if you survive with a good quality of life. This is 47% absolute number, not of the survivor, okay? So you won't be stuck in a persistent vegetative state. And these characteristic of this trial resumes what's important about the management of the arrest itself. If it was witnessed, if you had a quick CPR performed, if you had a shockable rhythm, and if your ROSC was within 25 minutes, you have better chance of good outcome. And I think the most important thing TTM or hypothermia did over the years was to improve the ROSC a brain could tolerate, the length of the ROSC. So now, there are guidelines to help you predict, and they're quite straightforward and easy to read. What's the first thing that needs to be appreciated is that your brain has to be happy. It has to swim in a happy physiological environment, so it works well. Then you can prognosticate. And the most important thing is that sedation and analgesia that you use while you're doing TTM needs to be out of the system. And these guidelines in 2006 suggested 12 hours of stopping before trying to prognosticate anything. Then the other important thing that you need to appreciate is that if you have criteria for brain death, then you can diagnose it at any time. Depending on local policies, you'll have variation around this, but you need to exclude confounders. There's no brainstem reflexes at all, no movement, and you can perform an apnea test or sort of an apnea test, and you see that there's no breathing movement at all. And if for whatever reason you cannot perform a clinical exam, you can perform an ancillary test, the cerebral conventional angiography being the gold standard. Then comes a series of tests that help predict poor outcome. The important thing to know here is not to get it wrong. So hence the importance of the false positive rate that has to be very low and the confidence interval that revolved around then. So as a clinician who's making a decision or a recommendation to the family, you have to be comfortable with the uncertainty around these things. So you'll have to feel that when you deal with patients. So before going through these predictors, you need to know that the literature is subject to the self-fulfilling prophecies. That is, withdrawal of life support is never protocolized in the studies, and some of the tests being studied are actually used to decide to withdraw care. So it's a very poor literature. So that being said, we can still come to meaningful conclusions. And the first thing that does not appear here, the clinical examination is the most important thing, and there was a big blown pupil on this slide. They are not, this is a very important sign, but not reliable in the first 24 hours. Reactivity is much more important because you can be brain dead with, mid-sized pupils, and nowadays there are equipment that can provide us with very, very sensitive measurements, and studies are ongoing to assess that and to help prognosticate. One needs to realize that the clinical exam tries to capture the return of consciousness that has anatomical correlates. The ascending reticular formation will progressively regain basic brainstem function like the corneal, the papillary reflex, and then more elaborate movements. But the eye the exam of the eye can be refined in this context. Either the patient has their eyes closed or open. But even if they're closed, you can open them and see how they react. So you have disconjugate gaze, conjugate roving, pursuit, fixation. That does not necessarily mean that you're conscious, does not require consciousness to occur. And then you can follow command. And this is very important to pick up patient that would be kind of locked in. The only way you'll know that they're not dead is by looking at their eyes and see if they obey command. And what is key is the ability to see improvement over time. So every day you need to assess this, and you see that they're moving forward, well then something is happening or recuperating. This brings me to what is consciousness, and this too has been refined, and I just want to tease you about where neurocritical care is going. Science has tried to explain simply consciousness around two main axes: wakefulness and awareness. And you can be, the persistent vegetative state is you have a patient with eyes open but nobody's home. There's a new condition that has emerged that is above vegetative state. Patients look like nobody's home, but there are glimmers of lights now and then, and this is what you need to try to pick up. And the eyes help you in that sense because it really is they improve in this trajectory towards recuperation. So even if you get to the point of the minimally conscious state, you still have a very long way to go, but you want to assess this improvement in time. The other important component of the exam is the Glasgow Coma Score motor part. With 1 is nothing moves, and 2 is the extensor posturing, which is quite different, that you need to differentiate from withdrawal. Nurses do stimulate the patients with pain, and as soon as they see a movement, they say there's withdrawal to pain, which is a good sign. You need to look for the repetitive, stereotype, rotating movement that actually is not withdrawal to pain, is actually a bad sign of recovery. So I think a lot of the times we have the impression that patients are moving and will move more, but it's actually very reflexive posturing. Myoclonus also has historically been associated with a bad outcome. Again, it comes from the Livy study. It is still true nowadays. If you have an early on myoclonic movements in the first 48 hours, it's not a good sign, but it does not have the false positive rate required to be used alone. You see this in 20 to 30% of your patients. So the clinical exam should be performed on day 3, and look at the pupil corneal reflex motor score and obviously the evolution in time, as I said. Now, more advanced things that could help you. Obviously, the brain creates electricity. Why not measure electricity? There's many malignant patterns of bad outcome, but none have the confidence interval or the false positive rate required to be used alone. Maybe a less known test that you can perform, and it is actually quite good, is the somatosensory evoked potential, where you stimulate the median nerve and you measure the electrical activity the cortex registers. If they're absent bilaterally, it carries a strong prognostic significance, and this has held true towards the decades that it has been studied. Biomarkers, no solid thresholds, the temporal profile is not determined. Imaging, we often hope that we'll get something out the images. It's useful to rule in catastrophes, and this scan shows dark brain, no issues there, the patient will do bad. This one here, less clear, and it's subject to interpretation, even with quantification tools. MRI, same thing. If you see this, the cortical laminar necrosis I was talking about, very rare, but a normal scan can be a double-edged sword when you're faced with a family who wants to hold on. So I'll finish with these the 2006 guidelines were updated in 2014 by the European Society of Intensive Care. Same thing, graded way to management. So at day 3, you assess the clinical examination. So if you have a motor posturing plus abnormal reflexes or abnormal SSEPs, you'll do bad. You can tell the family that you need to stop. If you don't have this, then you need to use alternate tests in combination, because none of them have in and of themselves enough power to predict. This is all well explained, and the timing is important, and they stretch the window of prognostication until 5 days, mainly to make sure that you will exclude confounders, especially sedation, in the event of hypothermia that can prolong the half-life elimination of many drugs that we use. So basically that's the reason. And if you have none of the factors, then you're stuck with an indeterminate outcome. Unfortunately, most patients do fall in the indeterminate outcome. So what you have to rely on is what I was stressing before. Doesn't matter, I'm almost finished. Your clinical exam, as it showed improvement over time. If you could put it up, though, again, because I'll need the last few slides. If you see improvement in time or you don't see improvement in time, it is a strong prognostic factor. And once you've reached 7 to 10 days, as Livy has showed us, if you're not awake by that time, the chances of you making a good CPC score of 1 and 2 is relatively impossible. You might wake up and not be perfect, but then time is important. And as Nick said, sometimes we see improvement a long time after the arrest. So, yeah. So, and then we're faced with the fact that we deal with humans and bioethics, ethical consideration. And at the end of the day, there will always be a weight of uncertainty. And personally, I think that this weight needs to rely mostly on our shoulders. We need to guide the families, but we need to make a decision at some points. And the way I do it, in my mind, I have 3 to 5 days in front of me. So I make multiple family meetings over a few days to understand who the patient is and what would describe to the family what would be acceptable and not acceptable in terms of daily activity of living. And I focus on clinical exam as a prognostic tool towards the family. So they too see that the patient is not improving. So it helps, making a grieving process. And at some point, you decide scientifically with a certain uncertainty where the patient will end up, and you sit down with the family. Was it compatible with the wishes? Unfortunately, still in 2017, most of the time it's not compatible with the family and the patient wishes. Sorry for the technological problems.
But it was very good.